Good afternoon, and thank you so much to all of you for joining this 1-hour webinar this afternoon. Delighted to have you here. I'm Julie Haddett-Miller. I'm an Associate Professor of Human Resource Management and Development at Middlesex University, and I'm a joint programme leader of our DBA in Healthcare Leadership along with Dr. Mary Hartog, who we can also see on the call. Mary is Director of Organisation Leadership Practice, and Mary and I both co-facilitate our new programme, the DBA in Healthcare Leadership, which launched last month, so the beginning of September. I'd like to say a few words about the DBA in Healthcare Leadership before we get started formally, and I introduce Roger Kline, and then Roger will introduce Amanda Oates and Terry Roberts. So the DBA in Healthcare Leadership is a new programme. It joins a suite of doctoral programmes at Middlesex University, and we are known in the work-based learning space. We have a number of doctorate routes, but this one was very specific, and then it's designed for senior leaders in the NHS and healthcare. Middlesex University has a long-standing relationship with the NHS and with healthcare organisations to create professional practice programmes. But this programme is really designed for those that want to facilitate and deliver change, strategic, cultural, organisational change. And so the 3 to 4 year programme involves developing and creating change, whatever that may be, within the participants' own organisational environment and perhaps broader and more widely. So this webinar series was created to run alongside that DBA programme. So the intention is that we have a 1-hour webinar every 1 to 2 months. We invite senior leaders from the NHS and healthcare organisations to discuss some of the challenges that they face within their organisations and how they're leading and managing change. Our colleague, Roger Kline, he's a research fellow at Middlesex University, but has many years experience within the NHS, healthcare practice and trade unions, is the leader for our webinar series. So Roger, fortunately, through his wide range of contacts, is able to invite a number of different senior leaders every month or two to come along and have a conversation around the challenges they face in their roles and how they address those. Now, just in terms of housekeeping, before I hand over to Roger, you'll be able to ask questions as we go along in this 1-hour session, and you can use the chat box to do so. And I will monitor those questions along with Mary and Christina and Aziza, and we'll raise those questions towards the end of the session and direct those either to Roger, Amanda or Terry. So please feel free to introduce yourself by the chat box and to pose any questions that you might have. As you will have heard, we're recording the session, so the link to the recording will be available subsequent to this. I believe Christina may also just be taking some screenshots, etc. So just to be aware of that as we transition through the hour. Our speakers do need to leave at 1 o'clock on the dot, so we'll be closing at 1. I've also popped in the chat box, and I'll do this as we go along in the session as well, the contact details for Dr. Mary Hartog. He's, as I said, is one of the programme leaders for the DBA in Healthcare Leadership. So if anyone here is interested in finding out more about the programme, you can contact Mary direct with the email that's in the chat box, which I'll post again towards the end of the session. Under Mary's email, there's also a link to the DBA in Healthcare Leadership, which takes you to the Middlesex University website, where you can read more about the programme, the duration and the costs, etc. And again, I'll post that at the end of the session should you wish to read more. But I'll hand over now to Roger Kline, and Roger will introduce both Amanda and Terry. Thank you, Roger.
Thank you, Julie, and welcome everybody. So I'm delighted to welcome today Amanda Oates and Terry Roberts. They are both well known. They're both former HR Directors of the Year in the NHS. Terry is the Chief People Officer at Oxford University Hospitals NHS Trust, and Amanda is the Executive Director of Workforce, I think I've got that right, at Mersey Care. And some of you will be familiar with the innovative work that both of them have done. I'm going to kick off by asking both of them the same question. and then one supplementary question, and then it'll be open to others to ask questions via the chat. So the opening question to both of you, perhaps Terry first. The budget yesterday has put a significant large amount of extra money into the NHS. But I think NHS organisations have all said it begs the question of who's going to do the work, which I think makes the role of HR particularly important. So can I ask you both, the NHS has got tremendous workforce challenges in terms of both staffing levels and how staff are treated. What are the big issues that you think HR can address to help to turn the NHS around from the difficult times it's had in the last few years? So perhaps Terry first and then Amanda.
Yeah, thanks, Roger. Really interesting question. Now, for me, there are quite a few challenges. I think one of them is strategic workforce planning. I think that's been a huge issue at a national level. Like we've been reliant on international recruitment, and actually we've not been preparing our organisations to receive those internationally educated staff as well. And we haven't invested enough in our domestic market and training our people, our local people, to want to go into careers in healthcare. Now, the long-term workforce plan seeks to do that, but it's going to take 20 years for us to build that market. And so that's a real issue for us, and how we align our operational, our finance and our people so that we've got good workforce planning. I think there's still a lot of work to be done on that. And that's a challenge, I think, that we haven't quite dealt with. The other big thing for me is around bullying and harassment, including sexual harassment. And I think historically, it has been accepted in some services as simply just the way things are. And if an individual is seen as performing, and that's surely on an operational level, or they've been excellent around in their particular field, then it's been overlooked. And I think the wider issues of the impact on people, on patient care, and on turnover and finances aren't either understood or are overlooked. I think there's also the productivity challenge and the integration of AI in HR processes as well, and managing that whole remote and hybrid piece around, and in-office issues. I think that's another challenge which I don't think we've quite got the full answer to yet. There's also, for me, another challenge about how we reimagine well-being at work as, normal practice, rather than as a perk which we can, utilize to recruit people. And then I think the biggest challenge, and I'm speaking purely as a HR professional here, is equipping our people to deal with these challenges, and equipping them to equip and coach our managers, rather than simply being an expert or given, or just waiting for them to come to us to help them. Unless we equip our managers, our everyday people, to address some of these issues, it's going to be a problem. And I think what we do need to do is to give our people, our HR professionals, the psychological standing to speak up. And that means that they'll have a sense of entitlement to speak up and to act. And so when something is seen as normal, that type of behavior is seen as normal in relation to bullying and harassment, they speak up and they don't cover it up or side with management. And there's also something around then giving them the psychological safety, because I do think there needs to be psychological standing first and then psychological safety. And for them to actually speak up as well. I'll stop there because I could waffle on forever.
You're not waffling at all, Terry. Thank you very much. Amanda, would you like to follow that? The same question. What's HR? How is HR going to address these challenges, or should it?
I really agree with some of the.
You're silent, Amanda.
Am I? Can you hear me now?
Bit loud. Can you make it a bit louder?
Gosh, that's not very often I get asked that question, Roger. Can you hear me now? Okay.
Yeah, I think that's fine.
Yeah, that's great. Okay, so absolutely agree with some of the comments Terry's made in relation to workforce planning and that whole pathway for people to come into the NHS and flourish and grow. So from a career entry point of view and onboarding perspective, attraction, retention, and making sure the opportunities for growth and development and them being funded so that people can progress in the NHS. I don't think we've paid enough attention to that as an NHS per se, and indeed probably private sectors are exactly the same. But we're in such an issue for attracting talent, it's got to be mission critical. But I suppose what you would expect me to say, and when I look at all the work we've done around restorative just culture, and I know, I'll talk about that till, I'm forever can talk about this like Terry. But I think the bit I would like to say, the first thing I think HR professionals need to do is hold the mirror up to themselves and the practice and the team that they operate within. And I think sometimes if we're really, really honest on that fact, we're very good at giving advice about change to other practices and services in terms of whether that organizational change, best leadership practice, new research and evidence, and applying that to practice in their settings. But how often as HR professionals do we hold the mirror up to yourself as a HR professional and indeed the team and do that, diagnostic dialogic approach in terms of what the services we do and how we do it. So, Terry talked about psychological safety, absolutely in the DNA in terms of making sure organizations are responsive to incidents and events that happen in everyday life. We operate in a human system. We're at the furthest away of, saying the computer says yes or no in terms of that relational side of care that we give and the advice that we provide really has an impact on the end user. So I would really say for HR colleagues to really look at how they speak that truth to power and have the psychological safety to do so, and be very aware of that advantage blindness that our leaders have in our organizations because of the positions of power that they sit in and the advantages that they may have in terms of whether that's a racial advantage, whether that's an ability advantage in terms of being able-bodied, that advantage blindness that leaders have. What are we doing to address that or support or asking those questions and being the bystanders in that process, speaking truth to power to help people see their blind spots? And I think that's really got to be a mission critical role of HR, asking the question, holding the mirror up to themselves as HR professionals about their blind spots and their team blind spots. Because if you don't do that to yourself, how are you supporting others to address their blind spots, either individually, team-wise? And I think if we don't do that, then we get a lot of tolerance about cultural inappropriateness and behaviors that play out because we're not speaking truth to power to ourselves. So we're not holding the mirror up as how I'm coming across as a leader, how I'm leading, how I seek feedback, how I ask for feedback. And regardless of what we think, I need to remind our HR colleagues that when somebody says, oh, you're seeing HR or HR is accompanying it, we're scary. So what are we doing to make our people feel that we're neutral in that space, that we're not just going to go to where we think that power basis is, that we really are able to speak that truth to power and give that constructive feedback? And then I think if we're able to do that, that starts to create a psychological safety, that foundation of psychological safety, and starts pulling into things about being more compassionate as individuals, as leaders, obviously making sure we're more open to learning and not blaming. So we've obviously got to stop the language of blame, because the language of blame perpetuates us feeling unsafe and stops honesty and transparency. I think we really need to focus on having collective leadership. So collective leadership, everybody's got a leadership ability and responsibility, no matter who you are and what role you are within the organization, and really creating an opportunity for open and honest dialogue. Because without that honesty in dialogue, then you may as well forget everything. People put the head down, they don't raise concerns, they don't give feedback because it doesn't make a difference. They don't give feedback, they don't feel like they belong. So we perpetuate the inequalities that we let exist within our healthcare settings and indeed our workplaces, and we're not asking those really uncomfortable questions. I think for me, there's often a misinterpretation of psychological safety being all soft and cuddly, and that we're not able to say that that relates to high trust, high challenge. And, you know, I always like that quote when we talk about bullying and harassment, is that nobody comes up with a good idea if you're being chased by a tiger and you don't want to be a tiger to somebody. But how do you know if you're a tiger or if you're not a tiger if you don't ask for that feedback? And as HR practitioners, how often do we ask for feedback on how we are experienced as leaders? Because if we don't do that ourselves, are we giving the platform for other leaders to seek that feedback? And it's only when somebody says to you, Amanda, you know, when you manage that dialogue or you deliver that organizational change or do you deliver that conversation on leadership, this is how I received it. And if people aren't giving you that feedback on how you come across as a leader, I hate to burst your bubble, but it's not that you're brilliant. It's probably and most likely that they don't feel able to give you that feedback. And that's a question we have to genuinely ask ourselves. If we're not getting the feedback or we're receiving any feedback on our style, because we're always an uncomfortable person to somebody, then we're not learning, we're not growing, and we're not speaking truth to power to ourselves or each other. And therefore, things will not get discussed. And if they don't get discussed, we don't learn. And therefore, we don't prevent the same things reoccurring time and time again. And I think, you know, the evidence says that's what happens in healthcare. And we've got to do more. And we've got a real responsibility to bring that to the table and be that moral compass in our organizations. But that has to start with us. So sorry, I've gone on a bit there. My apologies.
I think you've both kicked off a really good conversation. So 2 short questions for you both, and then I'm going to open it up. Actually, Amanda, if you don't mind, I'll carry on with your. No, let me go to Terry first. You can catch your breath. Terry, one of the biggest challenges in the health service is 26% of our staff are from Black and minority ethnic heritage. We have failed really to do what we ought to have done to make sure they're all treated with respect, welcomed, supported, their talent developed, and so on. What's your view on what else we need to do? Because the pace of improvement has been pretty glacial. And in a moment, Amanda, I'll ask you if I may to say a little bit about the just and learning culture you pioneered, but come to that in a moment. So Terry.
Yeah, I mean, like, if we look back, you know, over the last 20 years, we can see, you know, all of the different initiatives that have been put in place, the legislation that have been put in place. And, you know, you're right, there's been slow progression. And for me, that comes down on, I'm going to look at the NHS. This is what I know. I think it's because we just haven't put the right accountability structures in place. And I think we're probably just focused a lot on hearts and minds. And that's good. We do need to get our hearts and minds together. But if there's not the accountability in place as well, then progress will be slow. And for me, there's something about, you know, how do we escalate the whole kind of like equality issues to a place where they become never events and they have board scrutiny? Like if we're looking at, you know, sexual misconduct, we're now looking at, okay, how do we make sure that actually when those things happen, that there is board scrutiny about how we're addressing it? And I don't think we've done that enough. For me, there's something about how we make boards, the most senior people in organizations, accountable for moving in that area, for making sure that, you know, the equity pay gap is minimized or becomes zero? How we held to account for that at board? For me, there's something about the role that the Department of Health and the NHS and NHSE, NHS England, what role do they play in this accountability? And how do they ensure that arm's length bodies are holding us to account as well? Are they pulling us in? So we'll get pulled in for different issues, and we'll be held to account for, and rightly so, for how we're managing our finances. We'll get held to account for waiting lists and how long they are, and rightly so. But are we held to account for the cultural issues that have a direct impact on our financial stability, that have a direct impact on patient safety, that have a direct impact on productivity? And so you can look like in a silo way at, finances, in a silo way around, waiting lists. But if you don't have a broader perspective, we're not going to really be able to tackle those issues. And so for me, it's around accountability and making sure that we link the accountability with the hearts and minds piece.
Thank you, Terry. Amanda, it's not unconnected with the last point, but you pioneered an approach that's been picked up quite widely in parts of the health service around the just and learning culture. Do you want to just say a little bit about how you feel, how that's situated in the current financial and political kind of environment? What role could that play taking things forward?
Well, I think, for me, a restorative just and learning culture is absolutely imperative, and it gives qualitative and quantitative impact. And in terms of some of our research studies has shown that there is an economic viability to the implementation of restorative practices for all the reasons that Terry's outlined. It does make a difference to the bottom end. If you think about it, just from a people process or a patient safety processes, the time it takes to look into something when something doesn't go to plan or as expected, or there's, worst case and ever event or something in the organization, the time that takes to really understand what's gone on. And my experience in the past, we've tended to look at, the human aspect of that without looking at the organizational learning in that respect. So I think having a more open and fair and transparent culture helps us to distinguish between contributory factors, of which there may be systemic issues and there may be individual culpability issues, but actually it helps us to take a step back and look holistically through each other's glasses in terms of getting an understanding of that context and the environment in which things happened, rather than applying, well, I know best because I'm the leader, or the bias of, well, I wouldn't have done that, I would have followed the rules. And we can tend to be very judgmental as human beings and have clear demarkers of right and wrong. And it's almost as if you can only be right and you can only be wrong. So, the only way I can be right is if Terry is wrong. And that is not the way to do business, and particularly in a healthcare setting, which relies so much on trust and relationships. So I think having the opportunity to have a culture where people feel safe, and I'm not saying that we've got this fully embedded in Merseycare. There's absolutely aspects and corner of Merseycare that would say it doesn't feel very just or restorative in this team. But we've got a commitment organisationally as a board to make sure that we're on a continuous learning journey. So every time we might get a sense of, oh gosh, aren't we doing something really, really great here? Something comes left of field and reminds us that we're not doing it in the way that we intended, or potentially with the intent that we intended, or having the impact that we wanted. But the whole presence of having a restorative approach is we take a step back, we listen, we engage, we learn, we seek to understand, not to write an action plan to say that we've closed that gap, but we seek to understand to hopefully prevent similar occurrences reoccurring in our organisation, because we've done that deep learning, we've closed the loop on the learning and tried to make sure that our interventions prevent something being repeated time and time again. And I think we have to really understand the context in which of our people operating day in, day out, and we have to set them up for success. And I think sometimes the way we manage and lead people doesn't set them up for success. The way we design roles, the way we design structures, the way we design systems and processes doesn't set our people up for success. If I was to ask you in your organisation, how many policies and procedures have you got? You've probably got hundreds. Some of you will have thousands, lots of operating practices. And our people are expected to operate within the rules of those practices. And often they do day in, day out, and things go brilliantly. But we then hone in on maybe the 2% of time when things don't go to plan, or that something has happened in that individual's working day that didn't go to plan or as expected. And then we seek to blame. And I think it's really, really important that the organisations that we work in really understand what we mean by fair and just and restorative cultures. Because I speak to a lot of organisations and people go, oh, yeah, we do that here. And I ask them it's really simple question. I say, well, what does it mean to you? And then they look at me sort of blankly, and they can't really articulate what an approach means. So it's really important our approaches organically grow within an organisation. They're not seen as, oh, we're just doing this latest swim. I'm sure lots of colleagues have been around long enough when we heard that every NHS had a good to great strategy, based on the principles of Jim Collins' book that was launched a number of years ago. And every trust you went to, everyone was talking about, oh, we're good and now we're now moving to great. We've got to be really careful that we understand what we're doing and why we're doing and how it's aligned to our strategy, and how there's congruence in terms of there's not a disconnection with what our people are saying on the ground to what we're espousing in our strategic documents and the values looking all lovely on the wall, how they lived and breathed, and how do we test that within our organisation environment to make sure that people are operating to those values. And particularly when you take the bullying and harassment aspect that Terry talked about earlier, or looking at civility and respect, and what does incivility and disrespect do within organisational context. It's really important that we have the mechanisms within our organisations to deal with these things, but those mechanisms are designed with our principles in mind. So we don't have all these values that espouse how we support one another, how we respect one another, but our systems and processes aren't in alignment with the values that we are articulating out. So we've got to live it in practice.
Thank you. Right, that's a really good kick-off from both of you. We're going to go into questions now. So I'm not sure. Julie, have you picked out a couple of questions, please?
Yeah, thank you. So we've got questions in the Q&A. We also had some initially coming through the chat box. So my apologies. In the introductions, I suggested questions go in the chat box, but they're actually to go in the Q&A. So if anyone does have any further questions, please pop them in the Q&A. We can capture them there. So as well as questions coming in, we've had lots of thanks and also lots of alignment with colleagues on the call, both saying to both Terry and Amanda by way of feedback that agree with many of the points that you've said so far. But a number of themes that have come from the questions. So one key theme is around prioritisation. So we've had a question from Jenny and also a question from Anna, very similar around this idea of prioritising. So Jenny's question, I'll read both of them because they're similar. So Jenny's question, how do we prioritise workforce planning when the dominant conversation is about saving money, particularly in the current financial situation? And then Anna's, which similar along the same line of prioritisation, thinking about, for example, when we retention and thinking about recruitment and efficiency measures with a pressurized system and all the pressures that we're facing, what do we prioritise? So similar
Right.
question, but what do we prioritise? Yeah.
Who wants to go first?
I'm happy to go first. So for me, it's around changing the narrative. And the narrative needs to be changed to who is it that's actually delivering the services? Spend in the NHS is mostly pay. Yeah, a lot of it is pay, and that's the cost of our people. Unless we invest in our people, unless we support the culture and the environment they're in so that they can be productive, we're losing money. You know, with turnover, you know, we're having to get people in and pay more for temporary staffing, for agency staff. We're having these cycles where we've got revolving doors, where we're having to recruit people more, spend more on recruitment. So for me, I think we need to make the narrative that actually we need to focus on our people, because it's our people who are going to enable us to deliver the performance that we want. It's our people that's going to enable us to deliver the finance around that we want. And we need to build our business cases based on that, based on the evidence that shows actually, if we reduced our turnover, this is how much we would save. If we kept our people happy and there was career progression, this is how much we'll save. We need to change the narrative.
Thank you, Terry. Amanda, do you want to add?
Yeah, I do like that, Terry, in terms of change the narrative. And I think, you know, the other aspect is around setting up our systems and processes so our people, if the work is simpler for them in the workplace. Some of the constant feedback I have is the mechanisms are clunky, or the policy doesn't work in practice. Everybody ignores the policy, or people follow the policy. Another unit's found an innovative way of doing something, but that isn't shared. So how are our structures and systems, how are our organizations designed that makes the work and the delivery of work simpler and safer for our people? So that goes back to our organizational design. So I don't mean moving the deck chairs. Do we understand the values that we add along a patient pathway, along their into you know their experience with us? Do we look at the whole person package in care, and how can we simplify that work to enable our people to have better time to care and do the jobs that they really, really want to do, and using things like digital technology to make things simpler and safer for them, and giving them information at their fingertips rather than having to look at 20 systems to find the information recorded in different ways and have multiple logs in. So there's a bit of coordination and simplification, I think, that we need to do, but it also goes back to our organizational design and then our job design to make sure people are doing the jobs we employed them to do, and they're not coming into us and then being frustrated because they're not doing the job that we promised, because our systems and our structures don't enable them to flourish or utilize their experience and creativity and curiosity in the way that we had hoped or originally intended. So I think we've got to align what we promise with what we can do in practice, and find a way of pulling together the design with the delivery so our people feel the impact. Because, you know, I go back to safety culture. The best safety culture you can create for our patients and our service users is that our staff feel safe first. You know, so if our staff feel safe, they feel more empowered and will apply that discretionary effort in a way that is unquantifiable in terms of the impact that they will have, if they feel that they're able to contribute in a way in terms of what they intended in the roles and jobs that so many of them love. I think they get frustrated a lot of the time.
Thank you, Amanda. Julie, next question.
Yeah, great, thank you. I think you've touched on this already, but Katerina, how do we build strategic workforce planning capability within the NHS?
Who wants to?
I mean, I suppose, Terry, I'll start there. I mean, this is obviously a passion of yours. You've talked about this. I think for me, it's probably a frustration over the years, I would say. I think we're not we haven't got the best systems to enable us to do that in terms of health. We're getting better, and I think we've shown some real progress in terms of some of the things that we've done. If you look at nurse associates and the pathways that we've taken within that workplace and the impact that they have. But sometimes I think in health we are disconnected. So, you know, I'll go back to the fact that we developed a sort of an agenda for change framework in terms of pay, and then we had a different sort of framework that those of you been around long enough will remember, the knowledge and skills framework, that didn't have the same aspects of evaluation as the pay framework. So I think there's something about, what do we mean by strategic workforce planning, and are we all cited on that now? I do think we've nailed that down now in terms of what we mean in terms of long-term planning, but actually where we're thinking of the measures we can do short-term, medium-term and long-term, because as Terry said before, some of the things that we do today are not going to bear fruit till 10 years down the line, and that can be frustrating for people. But we really need to understand in terms of the whole onboarding experience and the life cycle of our people better to help us plan better in the future. So I think we tend to think just in the numerical workforce plans in terms of the jobs that have existed and the professional boundaries that have existed for a long time. I'm not sure yet we've connected how digital innovation, even using things like AI in the future, could change people's roles, and what should we be thinking about now in terms of creating those roles for the future, designing them in that way now, and bringing in different skills and experience and different generational thinking to help us plan for the future that we can't see yet because we're blinded by what's in the now. So there's a bit of trying to connect that I don't think we've got quite right in the NHS.
Terry, do you want to add to that?
I would agree with Amanda that part of this is around systems, and we don't have effective systems that enable us to plan properly. All the systems we have are speaking different languages. So when we're looking to align activity with the number of people that we're using and how much money that we have, what is in our financial envelope, it's really difficult to do. And that's just for planning for next year or the year afterwards. There's also something around how we make sure that we're aligning with the long-term workforce plan, which is looking for us to utilize our local people and have things like Amanda suggested, different associates, shorten kind of like the length of time it's taking for courses. How are we, making sure that the barriers to that are being addressed? We've got real issues with, I think, even things like apprenticeships and how we utilize the apprenticeship levy. And, there's barriers to us even creating an apprenticeship because the backfill costs are prohibitive. And what that means is that, it takes about 7 years for the business case to work for us to put in an apprentice. And if we're being challenged year on year about our finances, most organizations are going to say, we can't afford that. We can't afford to do that this year. And it's only forward thinking, all those organizations that have a big backlog, that have funding and spare money, who can actually say, yes, this actually makes sense. And it's going to save us money in year 3, in year 4, in year 5. And there's something around how we utilize that money that's going off to the Treasury, which actually we'll never see. So there's something about how we work nationally and what happens nationally and how we're allowed to utilize our systems. There's something around aligning our systems so that they're all speaking the same languages, and how we recruit locally and create more apprenticeships roles that actually feeds our organizations so that we're not having to go out and be dependent on as much on international recruitment, but being clear that actually for the next 5 years, we know that we're going to need it and we haven't got enough trainees. And so this is what we're going to have to do and how we're going to have to do it. So it's a bit of a long-winded answer, but it's actually very complex. And I think that there is something about how much the government puts money to release us to do that effectively as well.
Julie, could I just pick one question out before I let you
sure.
do the next one? So there's a number of points being made about culture. So there are organisations that understand what you're both saying and try to act on it. And I'll word this as politely as I can. There are others who either can't or don't want to, and focus much more on reputational management, on a top-down approach, and so on. What do you say to HR colleagues in those organisations who maybe do want to adopt a much better approach to culture in the face of a resistance to doing so? It's a real challenge. It's not just an HR challenge, but I think, you know, you kind of get it. And I just wonder if you've got some polite thoughts about what we do about that, because it's a real problem.
I think it is a real problem, Roger. And I think, you know, I've got a lot of sympathy, and I've been in that place myself. I think first and foremost is when you're in a place of adversity and there's challenge or conflict, or, you know, a really sort of big issue. There could be an external inquiry, a CQC inspection, external review. All of those things bring a pressure, and it's very easy to be defensive and get into that litigation sort of process or put the brick walls up. But I think sometimes when we've been there, and I've been there myself, we absolutely miss the point. And we miss the point of what we're trying to get through and solve, because we get into that battle mode. And my experience of dealing with organisations who are not receptive to trying a different way, it's often based on vulnerability and fear. The fear of, if I'm going to do something different, it's an acknowledgement that what I've done previously is wrong, bad, misplaced. So therefore, it's easier to defend my position rather than lean in and say, you know, I handled that not in the best way. I could have done this differently, and say those words, I am sorry, authentically, you know, not, well, I'm sorry, that's your perception. So I don't mean that sort of an apology. I mean an apology based on authentic apology, which says, I, as a leader, or it might be we, didn't handle something in the way that we could have handled it, and I'll learn from that, and I'll learn from it, and this is what I'm going to do differently, or this is what we're going to do differently, and this is how we're going to address it, and potentially restore and rebuild the relationship. I think there's a lot of people in leadership positions still today that have a fear of admitting that they are fallible, or they are vulnerable in that space. So they go into a defensive space. And that goes back into the fact that, you know, some cultures are a blame culture, and that perpetuates fear. And if you've got a blame culture, you're setting your people up to fail, not to succeed. So I think we've got to really be honest. What's the language of dialogue that we use when something doesn't go to plan or as expected? Are we saying, well, who did it? You know, what did they do wrong? Why didn't they follow the rules? Why didn't they do this? What are you doing about it? Are you holding them accountable? I hear that a lot. Are they being held accountable? Are they being punished? Now, of course, there's always things where people do things very, very sadly. I don't need to say the cases where that's very prevalent and very public at the moment, that we can't make those cases change the majority of people who come and work at the health service, who get up and do really, really difficult work in complex and challenging environments and bring the best of themselves every single day. Are they always on their A game? No. Who is? Are any of you always on your A game? Have we got problems, worries, concerns that we bring into work and we can't leave at the front door? Of course we can. But where we have that dialogue and those relationships with our peers and our supervisors that says, you know, I'm really struggling today. I've got this going on. How can you support me in what's going on in my life? Then it actually makes the organization a safer place, because it makes it a real place. We're real, we're human, we're fallible, we make mistakes, and we learn and we build and we move on. But I think as leaders, you know, we're not very good at saying, I could be better, or this is what I need to be my best from you.
Thank you. Terry, do you want to add to that?
So I agree with Amanda, and I think a lot of this is driven by fear. and it's around the culture of the organization, and how we, the real issue for me is, how do we change that culture of the organization? How do we become an organization where there is psychological safety, where we've built psychological standing so people can raise those issues and feel free to constructively tell people this is an issue, and also people feel able to be vulnerable, and so that they can actually get to a resolution at an early stage. And we get into this combative mode, and actually nobody wins. But part of that is also does come back to accountability and what our leaders are held accountable for. And sometimes if they're getting beaten up about something, rather than being a buffer, they then pass that on and they beat somebody else up, or they beat the next person up. And it's about actually having the strength of character to resist that urge.
Thank you. Julie.
Thank you. Right, so various quite specific questions, but there's one here around existing roles. So how can we better use existing roles such as staff wellbeing, NEDs and CPOs to affect large-scale change in culture? Can anyone share good practice? Obviously, Amanda, Terry first.
I mean, I suppose the first thing I would do in that space is ask the organisation. So you've got lots of data in your organisation, haven't you? Staff survey, HR data, patient safety data. That gives you a certain amount of intelligence. But I would use that dialogical, the conversational aspects to look at people who've been through patient safety processes, look at people who've raised concerns of bullying, harassment, engage with your staff side and do things in partnership together, and ask your organisation, what's the biggest barrier to delivering the best care or providing the best service, whatever sort of background you're in, is, and listen to what your people say. In our experience, and in my experience, when I speak to that honestly in organizations, a lot of them go back to that fear and blame. They talk about that, about I'm scared of doing something because I don't want to be blamed for it if it goes wrong, or this happened to that team over there when that occurred, and so I'm not going to do it, just keep my head down. You've got to start with what is the voice of your people. What are they saying to you are your biggest concerns, but you can't just look at it from a staff survey. Go out and have conversations, speak to the people that you really don't want to speak to, that maybe have raised complaints or raised concerns. They've said that HR hasn't helped them. They've said this hasn't gone to plan. They've said the manager's being blamey. Speak to those individuals, and your staff side will have, and freedom to speak up will have great, sort of networks to say, I think it's really valuable that you have a conversation. Because when I speak to people in that space, they're coming to tell me of their experience. It's very, what you've kind of also got to say to yourself as HR practitioners is, don't just sit in the room and be Amanda Oates, CPO, and this is the professional line that I'm going to take. Be human. Let's not forget, we're all human beings in this space. And I think it's so much more authentic if we kind of lose the title and just go in there as a human being and listen to the impact. And even if you don't agree that the process that you enacted was inappropriate or the team did something brilliant, it's the way it's done, in my experience, and the perception of how that's handled or mismanaged. Listen to those stories, bring them up, flush them out, and you'll get a sort of an understanding of your organisation that you possibly haven't had just by looking at the metrics. So I'd really tease that out and let something organically come about within the organisation. Because then if you do an intervention, you can say to the organisation, I've spoken to our people and this is what our people have told me. And this is what we're going to do based on what our people have said. And we went back out and said, right, you've told me all of this. Metrics say this. Conversation said this. This is what I think you're telling me. Is that right? So where do we prioritize? And let them tell you and let it grow organically. Not like, otherwise it feels very disingenuous and off the shelf.
Thank you. Thank you both.
I would agree. I would agree with that. Co-created solutions where our people are involved and engaged in those solutions is the best way forward. And for me, my vision is that everybody becomes a freedom to speak up champion. Yeah. So it's not just, we're not just putting it on this group. We're not just putting it on HR, but actually we're equipping the whole organization to speak up. And when you do that, then actually we're utilizing everybody, not just a few.
Julie?
There's a great question by Wynne, actually, which is probably a great closing question. So I may be a few minutes early with this one, but it's just come up there with, what would Amanda and Terry want their legacy to be from their careers? Yeah, perhaps that's the closing question.
Older than they are.
So for me, it would be that he made a difference for people and patients. Full stop. And in a positive difference, by the way.
Lovely legacy, Terry. And I suppose I couldn't disagree with that either. But I think for me, it would be changing the face of how HR do HR. You know, people before process. Pause before you react and listen to understand. And the more our people do that, then, you know, maybe in the future you don't need HR because you're supporting one another in getting the best out of each other and resolving things yourself. Suppose that's a Nirvana moment.
Nothing wrong with Nirvana moments. I have them myself occasionally. Julie.
Thank you. There's the couple of comments in Lynn. Love that vision, Amanda. Yeah. So there's 2 or 3 questions around sharing and the theme of sort of sharing practice externally. And I'm just scrolling up and down to look for one of the 2 or 3 specific questions. But there's a theme here about sharing both good practice outside of your organizations, but also there was a note about subpar practice, and what responsibility do you have to share outside of your own organizations?
Who wants to go first?
I don't mind going first. I mean, I think we all have an obligation. I've seen stuff that Terry shared. I'm sure colleagues have seen people that that I've shared. There's lots of stuff on my trust intranet site that's accessible and available for people to use. We deliver lots of training for other organizations on restorative practice. So I think there is an obligation to keep sharing and pressing the word that we can do HR differently. And I think we all in this space have an obligation to do that. But you know what? We can be different colleagues. We can be different leaders. So I think the challenge is, let's be constructively different and think to ourselves, what can we do to grow as human beings? And even if it's as simple as, rather than reacting, just take a step back and pause and ask the question, why? Why is that the case? And are the people, you know, feeling low? Are they tired? Is the resilience an issue, rather than jumping to conclusions? So I think we've got an obligation to do that to ourselves first, you know, and then help others.
Yeah, and I would agree with that. I think for me, the key thing is around how you co-create with your people to develop solutions that work for all of your people, not just part or the senior people or the nurses or the doctors, but co-creation of solutions that meet all of the needs. Because for me, inclusivity is something which actually has its own payback. And when we have, you know, teams that all think alike, no one thinks very much.
So if I may, Julie, just say something on that. I think what surprises me and what I regard as probably the biggest difference between organizations that are going to do well and those that are going to struggle is this reluctance to be open about issues. So one of the things that I think should be shared is when things don't go well. We often learn much more when things don't go well about how to do them better next time And as I think Amanda said earlier, we're focused, right, who made the mistake? Let's deal with them, rather than what can we learn to share. Organizations are very reluctant to, in my experience, to say, well, we've done this and it worked quite well, in case next year it didn't go quite so well and they think they're going to look stupid. And the second thing I would sort of say, and perhaps this is a half a question, I keep going to organizations and meeting and reading reports from organizations where it's very clear that the emphasis is on spin. So you will see, for example, res reports that kind of pick out the things where there's progress, or WDES reports, and somehow or other not mention the ones where there's no progress, where actually the ones where there's no progress are the ones we should really be looking at. So how do we make organizations be more open about their shortcomings in order that we can all learn from them? It seems to me and dare I say it, this is a problem for national organizations too. NHS England's had a real issue over time with saying, do you know what, we're not getting this right, or actually we should have been open about this. So it's as much a statement as a question, but you may have comments on it.
So I do, and I think it's about, when we look at standard work or innovation or QI, actually they talk a lot about failing fast, don't they? Yeah, so that you learn, and we need to push that concept of that failing isn't a failure if you learn from it. And what we're not doing is making that obvious and facilitating failing fast and learning from that failing. And I think if we can develop that culture and encourage that, it's all over the research that's what you need to do. But I don't think we've translated the theory into practice.
Amanda, do you want to add?
Yeah, I think for me, all I'd add to what Terry's already said is what I said a bit earlier. It's about cultural tolerance. So we accept things, or we choose not to see things, or we have that advantage blindness. So I'll ignore all of that because I can, because I've got that advantage and I'm in a positional power. So I can say to the, strip that out, that's being a bit too blunt, and we'll draw attention to that and ask those questions. So you've got to be, I think, really in your board appointment processes and your governance structures, you've got to be very clear in those leadership positions that I suppose you're not burying something that we need to be transparent about, and we're putting a spotlight on the things, because the things that tend to have a spotlight on are the things that we tend to improve, and where we're not getting it right, what are we doing about it? So I think in terms of what a lot of organizations do, res and des and all of those sorts of things, is we write lots of action plans, but we're not writing trajectory improvement plans to say, okay, this is the gap, this is our hypothesis, is we need to improve that by 1%. So in quarter one, we improve it by a quarter. And then if we're not improving it by a quarter, what are we doing about it? So we tend to be good at writing action plans, but not what our expectations are in terms of deliverables and outcomes, and where we are making a statement to say that in the next 2-3 years, we're proposing that will shift by these interventions. And if we align to our interventions to our data, we can then assess, are our interventions working? But we have to be mindful in that, going back to the point that Terry made, because sometimes things are long in the making and long in the deliverable, and particularly things on cultural change and inequalities, we know that are very much so. But I think if we measure it intentionally and we're honest about that, then it maybe plants a different lens on it.
Thank you. I'm conscious of the time. Terry, have you got one quick comment, and then I'm going to start to wrap it up and hand it back to Julie.
No, I think I've made enough comments already.
Right, I'm going to, we've got 2 minutes, I think, left. I'm going to thank Amanda and Terry for being pretty open and honest about some of the challenges we face. I think the budget writes them in capital letters, and I hope that for colleagues listening, it's been thoughtful, and well, you'll have some things to think about going away. So I'm going to hand back to Julie, who's in charge overall here, and you're going to wrap it up.
Yes, thanks so much, Roger. And also our thanks to Terry and Amanda for your time today and really great insight. For those of you that are interested in the DBA programme in healthcare leadership, our next cohort commences January 2025. In the chat box, several times I've popped in Dr. Mary Hartog's email there. So welcome to email Mary, or just visit the link where you'll see more about that. We aim to run these webinars every 6 to 8 weeks to support the DBA. So thanks again for joining, and hope to see you again at our next webinar. Thank you.
Thank you.
Thank you, everyone. Bye now.
Thank you,
Bye-bye.
Amanda.
Thanks, Amanda. Thank
Bye-bye.
you.
Bye.